Yeah.
Good morning, everyone. Thank you for being here today and welcome to this lovely venue. We've had a very interesting and informative tour of the different wards and areas. So I thank you to all the staff for explaining so many things to us and giving us so much information. That's been great. So I'll move on now to the first item on the agenda for this morning, which is the appointment of a chair for the purposes of the meeting. And I would like to nominate Mary Layton, who is a Darlington Borough Council councillor. Would anyone like to second me on that, please?
Could I second, please?
Thank you, Evelyn. Would everyone, do we need to vote now? Or is everyone in? We need to vote, Hannah? I'm looking at you for guidance, thank you. So, do we put our hands up? Thank you. Would you please show your hand if you'd like to indicate that Mary become chair for this meeting? Thank you. I would think it's unanimous. Thank you. Great vote of confidence in you, Mary. No pressure. Thank you, Mary. I'll hand over to Mary now.
Good morning, everyone, and thank you all for coming along. It's been an amazing turnout. So I'll just, if you bear with me, I think the last time I was telling Alma, the last time I'd chaired a meeting was Manchester University Mountaineering Club. And I think we all ended up in hospital after the first trip out, so let's hope it goes a bit better. So I think we just want to, is it the attendance of the meeting? Have we got any apologies at all?
Yeah, I've got apologies from Councillor Rob Cook and Councillor Dorothy Davison.
I'm Councillor Paul Weston. I'm subbing for Councillor Claire Gamble.
Right. Thank you. And then the next, on to 3, just the declaration of interests. Anybody have a declaration of interest at all? I'm trying to look for the councillors dotted amongst everybody. So, right, and I think we can move on then to the minutes of the meeting held on the 18th of March 2022. It seems like eons ago, doesn't it? So I don't know whether you've had a chance to read your minutes and whether everyone agrees that it's a true account. Have you got a...
Just a couple of comments.
Yes,
if I
certainly.
may, just sort of matters arising,
Yep.
if I may, Chair. If we can look at page 6 of the minutes, we talked about directors of lived experience. They were recruited, but I'd really like to know who was appointed. The CQC recognised enlarging the skill base of directors here at Tuve, and in response to the ZZ Coroner's report to take action, we need to know who the directors are. Sally Smith was appointed co-creation, which has a remit of involvement of patients, and the medical director we now know is Dr. Kedar Kale, who I think is in post from the 27th of this month. And is there any progress on the safeguarding leave? At our last meeting, I was reassured by really what Mr. Brian Hanna said. He recognised the significant changes in the leadership team. He said the CQC will focus on these changes aimed at strengthening the board and determine if it has a desired impact on the service. And secondly, I'd like to ask you to look at page 7, and it's the second bullet point. Numbers were provided. They were percentages. This was to SBC in response to our request. Large numbers in relation to the establishment, but they needed to be in context. They did not show staff stress records, dismissals, overtime worked. Tripled use of agency staff occurred in January, February 22 in the forensic services, and almost 3/4 of shifts worked in the same period in the same service were bank staff. We need to know how many, really, to measure the impact. Therefore, in my opinion, Stockton Borough Council had no option other than to write to the Secretary of State for Health and Social Care, the Right Honourable Sajid Javid, requesting a public inquiry, and it was in fact a cross-party decision of that council. I did criticise Stockton's lead governor of Tuve, as I see the overriding role of the Council of Governors is to hold the non-executive directors to account and represent the interest of the NHS Foundation Trust members and the public. As far as I am aware, they have not seen fit to raise concerns. They received a briefing email from the Director of Corporate Affairs and Involvement expressing her disappointment at Stockton's action the day after Anne Bridges met with the Chair and Vice Chair of this committee, and it would be nice to get a little bit of clarification on that. I welcome the visit to Rosebery Park at the very first opportunity today, and I have no regrets about requesting the government to take action timely as Tuve responds by the 21st of this month as they outline the support they would provide for autistic people. So thank you for allowing me to say that.
No, thank you very much indeed for that. I was wondering, is there anybody that has any response that can... Thank you very much.
Thank you, Madam Chairman. Just in response to the comments about myself as lead governor and the governors of Tuve, I can absolutely reassure this committee that the Council of Governors regularly have questioned, asked for presentations, asked for evidence of what is going on, what was happening, how the trusts were working towards the problems that they had, and I didn't know this was going to be raised, but I did happen to bring with me, I attended an event which was laid on for staff right across the trust, and it was reflective practice in organisations was the but I took the opportunity while I was there to speak to staff, various members of staff, and I did it in a very informal way so that I could satisfy myself that they felt they could tell me what they wanted to tell me, and I said to them quite categorically, Chatham House rules, won't use your name or even where, which service you're in, and I reported back, and as I always do, to the Council of Governors, and I asked them 3 questions, the staff, and I think you will hopefully agree that you've heard this today from the staff yourself. Do you think the trust is improving? Is morale improving? Have you been affected by recent adverse publicity? And the response that they said was that everyone I spoke to said things are improving with the increase in staff levels, whether that is agency, etc. They said that that is improving morale. Morale is improving. There is less pressure, which I think you've heard today, because of the improved staff levels, also because they feel the commitment of the trust to implement improvements. I asked them if they had been affected by the adverse publicity, and they said they felt disheartened by the publicity because they feel that people outside the trust do not understand or appreciate how hard staff are working to help the trust to improve, and they are committed to improve and deliver the best service for those who need mental health services. Now, as I normally do, any report that I do goes to all governors and they have the opportunity to question. So I just wanted to reassure this committee that the Council of Governors have held, we had a special meeting to hold how we hold NEDs to account, and we're going to have that again to update that. So I just really repudiate everything that was said about the Council of Governors. Thank you, Chair.
Thank you. And Anne, would you like to comment further?
Yes, thank you, Chair. Just to come back on the appointments of our lived experience directors, we have Chris Morton, who will be our lived experience director for the Durham Tees Valley and Forensics Care Group. He starts on Monday coming, on the 13th of June, and on the 4th of July we have a chap called Charles Naziri starting, and he'll cover the North Yorkshire, York and Selby Care Group. And we're really looking forward to those appointments coming into play, you know, bringing a different lens to what we do and using their lived experience in a really positive way, particularly in achieving our 2 goals around co-creation with patients, service users and carers as well. Just to answer the point around, I met with Alma and with Mary, just to agree arrangements for today more than anything else. The email that you referred to, Councillor Hall, that was you know, on behalf of the Trust. Of course, we were disappointed that the letter did go into the Secretary of State in terms of the public inquiry, but hopefully from what you've seen and heard today and what we're about to take you through, will hopefully provide you with the reassurance that you all need. Thanks.
Would anybody else like to add anything? Thank you, Brent.
Thanks, Chair. Just to pick up some of the specifics that you've referenced, Councillor Hall will deal with in the presentation. So in terms of the numbers and various other aspects, you asked a question about the safeguarding doctor. You're correct that we have appointed Kedar Kali as our incoming medical director, and he will be with us before the end of the month. And in the interim, we've been recruiting for a safeguarding doctor lead, and in the meantime, Dr. Steve Wright, who's our interim medical director, has been fulfilling that function.
Thank you very much. Does anybody else like to add anything at all? Did you want to come back at all, Lynn?
No, that's fine.
Right, thank you very much. If there's no more to be said on the minutes of the last meeting, I can just juggle back. Yeah, I was just going to say, are we happy to sign off with the inclusion of the notes that Lynn's added? Thank you very much indeed. Right, is it okay to move on? The protocol. Right. So, there we go. So I think now on the agenda item 5, we have the protocol for the Tees Valley Scrutiny Joint Committee. And just before you read through it, Hannah's advised me that point 6, the clinical commissioning group, on the 1st of July will actually change to being the Integrated Care Board. So I don't know whether, Dave, you want to make a comment on that, because it'll help us understand that transition.
Yeah, I think it might be useful because we've got this with all committees, with health and wellbeing boards, etc.
Thank you.
So absolutely right, Chair. On the 1st of July, the Integrated Care Board becomes the statutory organisation across the North East and North Cumbria. What that means, in effect, is 8 CCGs become one. A different organisation, but the 8 CCGs and the staff within them become one, which is the key bit. Because what I was going to say is that looking at your terms of reference, it would make sense to say that the Integrated Care Board would play into this. It would probably be the same people that you've had locally anyway, because we know relationships are really important. So once we know who the people are, we'll confirm them. But probably all terms of reference for health and wellbeing boards and scrutiny committees need to just reflect that change from the 1st of July. Right. Thank you.
Has everyone had a chance to have a look at the protocol? And I just wondered, are there any issues anyone would like to bring up? No, do we have to
Just sign off with that.
sign off as well? Is everyone happy to accept that with the...
Excuse me.
Sorry.
I just wondered who should be in, are we going to nominate Vice Chair for this meeting? I know it wasn't on the agenda, but it's...
So we've just nominated a chair for this meeting only because Darlington hasn't actually appointed 2 of its other councillors for this committee. So we'll do the appointment of chair and vice chair at the next meeting.
Okay, thank you.
Sorry, I forgot to mention that. Right. Was there anything else on the protocol at all? And we're happy to have that go through. Right, thank you. Right, on to next. And so I think we're having, is it the presentation we're having for the Teesgan-Esk Valley NHS Foundation Trust, the quality accounts for 2021-22. Is that, are we having a presentation? Is
Okay,
it?
thank you, Chair. Yes.
Thank you, Chris.
So if we can, and if you can go to the next slide, please. So clearly, this is not the main item on your agenda today, but the quality account, it's one element of our overall journey to change in TUV. But it is the element where we have a statutory duty to consult yourselves as Wellbeing Scrutiny committees, along with Health Watch and commissioners, to make sure that we get your comments on the document, which we need by Monday. So, and that's because we actually need to then publish your comments along with the other comments that we receive verbatim in what goes onto our website and what goes to NHS England, which we have to do by the end of June. So we do very much appreciate councillors giving us time on this agenda to make sure we can get that. Now, obviously, as some of you, Rose, I'm sure you've all read it, and you'll spot it as a 75-page document. It's quite difficult to read in places. Some of that is because the government, the Department of Health, specify the format and some of the text that we have to use. And so that's why we've done a presentation to try and pull out the main things that will be of interest to councillors. Again, I know you've had this in advance and that time is short, so we're just going to go through the main points just to allow you then to put any questions in that you want. But I am mindful that some of the questions you might have had about this will actually be dealt with in the main presentation that is to follow, or in the questions and answers that you've already given in and had answers for. So if we can move on, please, Anne. Move on again. So the first part of the presentation is about our quality metrics. Now, I would say, Chief, we've always had the view that we should set ourselves stretching targets. So one of the reasons why there's a number of reds on these 3 pages is because we have set very stretching targets. But there are a couple of the targets where we are not anywhere near to them as we would like to be. So one of them is that first one there, about the percentage of patients who feel safe on the wards. Although we have had some marginal improvements, that we're basically talking about a third of patients who don't feel safe on our wards. We continue to want to tackle that. We think that the additional staffing that we've already that was mentioned earlier on will go somewhere towards doing that, but also we have other things that we are doing as well. And we will include this as a quality account priority again in next year's plan, because we want to keep a focus on it. The other one of interest is the bottom one on that page, which is around instances of restraint. I know there's a lot of detail on that in the question and answer thing that you all have, but just to say that at least some of that is driven by things that have been going on in the adult learning disability and how we deal with patients who have some very specific and sometimes very complex needs. So if we can move on again, there's nothing particularly of note on that page, so we'll move on again. And again, you'll see there's, again, a lot of red on this page, but you'll see that most of those targets we've missed very marginally, or indeed in one case for the 40 said boroughs, but not including Darlington, we've actually managed to achieve the targets. So this is a slightly different kettle of fish, if you like, to the first page, where these ones, we have set very stretching targets, we're almost meeting them, and we will continue to do lots of incremental change to try and make sure that we do actually start to get to that 94% target that we want to achieve. So, and that's some of the things that we've taken in response to, that we're doing in response to quality metrics. Rather than go through those now, we'll scoot through this, and that will allow more time for questions if you have them, which myself and Avril will be very willing to answer. So if we move on again. For 2023, it's worth saying that we're currently just started work on developing a new quality and safety journey, if you like, a new strategy for quality in the organisation. That will give us a chance to rethink what it is, what in the long term we want our quality metrics to be. In the short term, we have actually got a revised board dashboard, which I think was included in your pack, which is the things, which includes the things that we are going to be, that the board will be monitoring this year. So if we move on again. During the year that's just finished, we did have 3 quality improvement priorities, which you can see there. We had 46 separate actions. Now, 30 of those were achieved or were on track, but 16 of them weren't. And mostly that's either due to the impact of COVID in terms of either diverting staff to doing other things or preventing us doing some of the care engagement that was important for some of these things, or it's because national policy has changed and some of those actions were no longer relevant anymore. So move on again, which is what that slide says there. So we'll move on again. For the year ahead, the 3 quality account priorities for improvement are those 3 there. So care planning, implementing the new patient safety incident reporting framework, and feeling safe. But I want to get across that it's not the only things that the Trust is doing to improve quality. We've got a whole raft of things in our business plan under our Journey for Change, which the Chief Executive Officer will be talking about later on. But those are the 3 specific ones that we're putting on our quality account, which we'll be very happy to come and feedback on through the partway through the year to tell you how we are doing on those. So we'll move on again. There's a lot of detail there about care planning, which you've had a chance to read, but ultimately we think this is very, very important. We've absolutely got to co-create care with our service users, and having care plans that people have inputted into and own is really important. During the year, there's something coming in called Dialogue, which is a system that that is best practice in the country. It's used in East London, East London Foundation Trust at the moment, and that will be being implemented throughout the year. And that will make sure that our care planning focuses on the things that our service using carers actually think are important for them. Because, of course, everybody is different and different people will have different things that matter to them. And it will help us get that personalisation correct. So if we move on again and again and again and again, we'll move on to feeling safe. Again, I'm going to give you the very broad headlines now. There's a chance to ask questions afterwards. So we'll be looking at the data. We'll also be looking at how we can make our staff more visible in adult and patient areas. We're looking at how we can use IT solutions to also try and make people feel safer on wards as well, and continue to do our Safe Wards initiative as well. And Avril will be very happy to, unless, do you want to add something to that? No? Okay. So move on again. We'll also be implementing a new patient safety incident reporting framework. And this is this will make sure that we are not just collecting the right data, but also that we're dealing with it quickly, and that actually our operational clinical staff will be able to actually understand what's happened elsewhere in the Trust, in other wards, and other community teams, learn the lessons and change their practice more quickly than we've been able to do in the past. So it will improve our overall quality and safety. So move on again. So in terms of what next, as I've said, we're very grateful for you giving us the time today. The latest we can take your comments is Monday the 13th of June, and I know, Hannah, you're primed to work with the Chair to do that, so thank you for that. The document will probably go to our Chief Board of Directors on the 16th of June, and then we have to publish it on our website on the 30th of June, and send it to Department of Health. And as always, we're very happy to come and do a 6-month progress report with you as well, which we'll look forward to doing at some point, usually around November time, maybe December, depending on how you want your meetings to run. So I'd like to thank the committee for their time, and Avril and I and others here are very happy to take any questions that you have.
Has anyone any questions? Would you like to go ahead? Thank you, Anne.
Thank you. You mentioned care planning as very important. I think it's the basis of your work. And I would like to see that it does involve patients, whatever their abilities. It needs to be available on the ward and available to the people who are working with the patient. And it has to be used, a daily tool, not just stuck in a box somewhere.
Yeah.
Yes, I think we would all agree with that, and I think the dialogue tool that Chris has referenced is very much, you know, that whole philosophy is the foundation, and for that brings. But clearly, a tool does not change people's behaviours, or you know, I suppose that compassionate care that families and patients, you know, get from the teams of people that are looking after them. So it's about an overall approach. It's not, you know, putting everything into having a system or a process that does make that information available, but it's people understanding how they use that information contemporaneously in a compassionate way that gives the best care. Yeah.
Would you like to go ahead, Evelyn?
Thanks. Just on that care planning side of things, I thought the dialogue system had been introduced quite some time ago, because I seem to remember you presenting it at that time, and I'm a bit surprised that at the moment you're saying it's now being introduced, and as from my understanding it was already in place. So could you explain that, please?
Yeah, I think we had intentions to have it implemented sooner than we have. There was also a process of testing out the process kind of on paper before we went live with the technical solution, I think. I think Brent wants to come in on that as well.
If I may, Chair, it's linked with our update that we're doing across our electronic patient record, which we call CETO. And that's a big piece of work that we've been doing for probably a good number of months now, probably about 18 months, if not slightly more, where we're looking to deploy it from September. And it's obviously, as part of that, there's been a lot of clinical input in the pathway design. There's been a lot of testing, end user testing, and those sorts of things. And it's going to be rolled out from September onwards. So we've been working it through. So it's been around, if you like, in terms of where we're at. And I think when we were talking about it in March, it was always with that intention that it would be coming later this year.
Through you, Chair. It's just that when we were told about it before, it was implied that it was already being introduced at that point. And it just concerns me that you're now saying it hasn't actually been introduced.
I apologise if that's the impression given, but there was never any intention for it to be it actually rolled out, if you like, before the rest of the electronic patient record system was in place, which again, I think if we go back to when we last discussed these, we were looking August, September at that point.
I just thought it was linked with the CQC, one of their initial reports, that one of the issues was the care planning that needed to be improved, and at that time I thought we were told that dialogue system was actually being introduced. So
perhaps if I could clarify, Chair, I wonder if it's linked with a previous CQC report. Obviously we've done a lot of work in terms of our safety plans and safety summaries, but that's in our existing electronic patient record, the Paris system. So we've actually done, you know, significant work in terms of actually updating that system, which has supported the processes within the wards for reviewing the safety plans and the summaries, so that they can be used contemporaneously and they're less complex and accessed. And that's what we've been doing. That's been the key focus on that side of things. The dialogue has always been linked with the rollout of CETO, which has always been scheduled for the kind of latter part of this year after the summer. So happy to clarify that, and apologies if we've given a different impression.
I think it was Lynn first, and then I think Rachel next.
Thank you, Chairman. I welcome the fact you've got 3 new priorities, and I listened to what Chris said. You know, we haven't thrown the others away. There is a raft underneath, and they clearly link directly with your CQC report. So I welcome that. And I look forward to hearing the key themes that come out of these patient experience groups, particularly with regard to safety and the care plans. And hopefully the care plans will mean that we're not working in silos any longer, and that we are working across core services and making a complete holistic care plan for the clients that are using the service. So I do welcome it. I look forward to November in getting feedback of the patient experience groups and whether any key themes come out of that, particularly on safety and the wider holistic care plans. Thank you.
Rachel?
Thank you. Thank you, Chair. I appreciate I'm new to this committee, and I'm sure that some of my colleagues with more experience might be able to put me right. But I'm particularly concerned about the number of incidents of physical intervention, and that it may be that we come to that at a later point or something like that, but I think that being so far off target is a real concern. And for me, I can't sit here and just assume that that's okay without raising it in some way. So can someone clarify whether we're going to be coming back to that, or whether that is something that is being tackled in a, for want of a better word?
Definitely.
Thank you.
Yeah, so I think, you know, we would agree that, you know, we would always want to be reducing any type of physical restraint as much as possible. It's about how realistic it is in terms of what, you know, what we can reduce that to, given the patients that we are caring for, and enabling them to, you know, to get as well as they possibly can. Sometimes it's not, you know, it's unavoidable, I would say, but we do have a whole work programme. So when Chris mentioned earlier the range of quality safety priorities that we have as an organisation over the next 3 to 5 years, reducing physical restraint and restrictive practices is one of our key work streams. We have a dedicated nurse consultant that's employed in the organisation who has particular expertise around that, and he sits and advises some of the national groups and works very collaboratively nationally to ensure that, you know, we are always working to best practice, evidence-based practice. We have a whole range of interventions in terms of skilling staff to understand when restraint is required, how best to do that, and training within the context of different areas, because it may be different wherever you're working, the geography of the area, for example. We've been reviewing our policies and practices. What I would say is that whole work stream is looking at it in its entirety, about how all of those key things come together to ultimately give us that impact of reduction where that is absolutely possible, and that restraint is safe, and then, you know, is safe for both patients and staff. I don't know if anyone wants to add some specifics.
Thank you, Mark.
Hi, I'm Associate Medical Director in the Secure Inpatient Service. I can comment on that area. That to support what Avril was saying, really, we've had from our Positive and Safe lead nurse consultant, we've had a lot of involvement from him within our service, particularly looking at staff reflections on incidents, making sure that that's kind of a very open and no holds barred discussion as to what people could have done better, what scenarios we would seek to intervene, and looking at the kind of the overall staff response across the site as well, and the way that's done, and make it as coordinated as possible, and to make sure that we focus on the information that we have and that's there on a daily basis. I think the introduction of the safety plans has had a massive impact upon how we interact with service users on a daily basis, particularly, I know some concern was raised earlier about the number of kind of agency and bank staff, and what the safety plans do is you have that kind of, it's not as simple as at a glance, but you have that information about a specific individual as to what behaviours mean, what to do in these situations, and what not to do as well. We found with some of my service users over time that the safety plans, if you look at the safety plans now compared to intervention plans, say 3-4 years ago, or 2-3, whenever anyone came to hospital, you can see that kind of development of the understanding within the staff team. So that it's that information and communication that's key. And we have reviews of the safety plans on a very regular basis. I've been in 2 report out meetings today where we review how everyone's been through the course of that day, and we have a review of those plans as well. So any incidents can be kind of discussed and reviewed in real time, rather than it being a longer period of time away. So there are steps we're taking. We work in an environment where there will be incidents, and that is a reality, but I think that we are trying to take steps to minimise the level of involvement and the number of incidents where it's avoidable.
Could I just come in with one more thing?
Yes.
It was just, as we're speaking, one of the developments is also the introduction of assurance panels that we're planning to put in place. So when there have been some, incidents of restraint, that we will routinely look at those to just to, I guess, reflect what Mark's saying, that they're doing kind of locally, and then we can look at those across an organisation to identify any key learning themes through those assurance panels. So that's something we're going to test out as we move forward and see how helpful they are, and we can develop those depending on, you know, on how useful we think those are. But that will bring another level of assurance that we're applying that in the right circumstances, using the right techniques. So I think that would just add something to that.
Would you like to come back?
Yeah, if you don't mind. So am I right in thinking that information will be shared in more detail other than that target with the Scrutiny Committee, for example?
Yeah, I think what we'll have in the first instance is internally we will convene assurance panels. So for currently, when we have a serious incident and it's reported, and there's a process, and that's one of the other priorities that we've got in this year, is around how we identify incidents of immediate learning. And it's a little bit on a parallel with that. So when there's an incident of restraint that we, maybe more of concern, then we would convene an assurance panel, and some of those incidents would be reviewed by senior people with the skills and expertise to be able to scrutinise that, and give ourselves assurance, identify learning so we can improve moving forward. And certainly we will be sharing how that goes in our work moving forward.
Is that all right? And would you like to come back?
Yes, please, on the same topic,
Yes,
really.
certainly.
I mean, I remember it's a year ago now, and we were having a Teams meeting, and this is a really high percentage in the T's, and I know Chris said it's linked to learning disabilities, principally because that's where they're based, in the T's, rather than the Durham and Darlington part of the service. But we haven't seen an improvement since, for instance, do we still not do eating disorders? It was put down to it being a lot to do with eating disorders, and we don't now provide that service here. And we were supposed to see a rapid reduction in restraints because of that. The other one that concerns me, of course, is always, as it concerns me, the dignity and respect score, and we need to get that up, really. We need to hopefully our clients can feel that they at least get dignity and respect in an inpatient situation. So that one concerns me too. But the restraint, I expected to see a bigger shift, because it was a year ago, I remember, on a Teams meeting when that was given as a reason.
I'm not sure if Dominic wanted to come in from
Dominic, do you want to come in?
So there's quite a large area that's covered under that title, and I think there's lots of layers that's underneath that we haven't really got into. So I'm not quite sure from your perspective what you think when you hear of those types of numbers and what in your mind you're saying is actually occurring. I think it probably is something that's worthy of greater exploration, because there is something around, not every incident leads to what we call a restrictive intervention. And in terms of those restrictive interventions, which restraints are part of, there are multiple types of restraints that can occur. There are multiple other types of interventions that can occur alongside that as well. So I do think it's probably worth getting underneath it and having a more detailed conversation to kind of clarify some of that. In terms of the point around eating disorders, I haven't got the numbers in front of me, but the numbers have dropped because there was, in terms of the particular ward, which was for young people, there was an awful lot of NG feeding, particularly that was done with restraint as part of that. So I think in terms of the proportionally, the numbers are now sit more from a T's perspective within the LD service. Those numbers don't include our secure inpatient service either, because that's a regional service. And I think the only other point I want to make was just picking up on what Mark described. What we have seen within secure inpatient services is that I've looked at the data, and where we've seen sometimes a rise in incidents, we're not seeing a proportionate rise in the level of restrictive interventions or restraints. So I think that's giving some form of assurance that actually people are attempting to use de-escalation and aren't kind of rushing to restraint. But I do think it's an area that would probably benefit from further detailed discussion and exploration.
Did you want to come back? I'll go to Evelyn, and then I think Patrick wants to come in as well. So.
Thanks very much. It's just on these metrics again, and particularly, I'm presuming they are benchmarked, and I just wonder which trust are you benchmarking against, and how are you comparing with things like that?
Yeah, so I think some of them are benchmarked, and they're benchmarked nationally. So, for example, the patient experience metrics, it's a national indicator that is, those questions are asked to all patients.
I really meant like a comparable trust, that it's sort of comparable areas.
Yeah, so I think some of that data is available through that national website, so you can look at all trusts and you can compare yourselves. I think we fare quite well around in terms of the patient experience. I remember when they were last published and we looked, I think we fared really quite well, and I think favourably against a neighbouring trust at that time. So where that information is available, we do look at that and make those comparisons.
It might be helpful to have some of that in this
we
sort
can
of
certainly
report
look
for
at doing
people
that,
to be able to compare against. Thank you.
And Patrick, did you want to come in? Right.
So I think the point of benchmarking is really important, and I think you're right, it needs to be context. So what you're seeing is an internal target and internal rates against that, but I do think the benchmarking is really important to contextualise us in a broader context. Where we do have benchmark data is within our secure inpatient service, so we can see there how we benchmark against other services. But again, there's another caveat around that in terms of the types of services you provide. So within the secure inpatient service within Rosebery Park, for instance, we provide what's called the female pathway for the whole of the North East and North Cumbria, and we know that historically levels of intervention in the female pathway tend to be higher than within male pathways. So again, it's about numbers tell you one thing, but I do think the contextualisation is really important in terms of the benchmarking, but I think it's really helpful to get under the skin of it and have a more detailed discussion.
Patrick, did you want to come in?
Thank you, Chair. Yes. So my name is Patrick Scott. I'm the recently appointed Managing Director for Durham Valley and our forensic care group. So it's good to have an opportunity to meet with colleagues today. All I would say is, I mean, colleagues around the table will speak in a much more informed and sophisticated way than myself in terms of what's gone on within the organisation. In terms of the here and now moving forward, this is a real significant area of focus for us, one of our priorities as a care group board. I think, and it speaks to many of the things we've already heard about today and other things that will be talked about in the next presentation, because actually getting it right in terms of opportunities to reduce things like restrictive practice and physical intervention speaks to the care planning process. If we get that right, a real collaborative process that helps us better understand the needs of individuals and how best to respond at times of severe distress. That's really important. Strengthening the collective leadership of teams and the working of clinical teams as well, as Dr. Spate and others have talked about, is really important in this. The appointment of the Lived Experience Director will be key for us as well, to help us think differently about how we engage and develop that sort of therapeutic environment within our inpatient services. And the other thing that we're doing, so for example, we touched on learning disability services over the last few weeks, been doing some very focused work within those services, one area of which is how can we better understand the opportunities to reduce the need for restrictive interventions. We're looking at that in terms of getting some shared learning from other organisations that have got some interesting models that we think we can learn from as well. So, and I think to Dominic's point, I think it'd be really helpful to come back and have a more detailed conversation around this somewhere down the line. Thank you.
I think we've got Anne first and then we've got Alma.
Thank you, Chair. While we're on safety, I'm not sure in this document whether it separates involvement of staff in ward problems or personal attacks on staff. I'd like to know how many of each there are, and I really feel that they need to be investigated on a different basis. You know, if staff are intervening in a ward incident, that is one method. If it's a personal attack on a member of staff, that requires different tactics. And I just wondered whether that is in this survey.
So we do collect that information as you've described it. We are able to, it's the way that we report it. So that information is is gained through staff actually reporting something through the DATIC system, which is our incident reporting system, where all incidents can be reviewed, and we can look at the numbers, and we can look at numbers over time, we can look at the detail of the incidents. There are various categories under violence and aggression and restraint, so it categorises them, and there are subcategories to that, so you can unpick all of that detailed information in terms of, you know, aggression against staff, patient on patient, and we're able to, I suppose, interrogate that information so that we can understand it better and report it separate in that way.
But the approach needs to be different.
In what respect?
The response of staff to an incident.
Okay, yeah.
Thank you.
If I could just
Yeah.
chip in, if I may, Chair. I mean, you know, the training is obviously geared for a number of different scenarios and settings. So, you know, clearly it would accommodate both of those examples that the councillors raised. And that's something it's a quality assured approach, which is governed by an external agency.
Right. Alma, did you want to come in?
Thank you, Chair. Did you want to come in, Jennifer? I saw. Okay, just so that you might
Sorry,
want to
Jennifer,
add something
didn't
there. Just two quick areas. Yes, I'm very interested in the benchmarking matrices, and I agree totally that we need to be very clear on that. Part of our maybe lack of understanding that you signalled, Dominic, was that we don't have the detail behind it. So we are seeing these figures, and that raises alarms, and maybe we don't fully understand. So I don't know to what extent we need to understand what's behind the matrices, because we don't need the detail that you need, but obviously we're raising these questions because we're not sure what to interpret from that. And I think it's important that we study the benchmarking matrices in comparison. That's one angle that we said of similar areas, but also linked to that comparability and analysis of the comparisons. I wondered how we learn from best practice when we see in our comparisons that certain other trusts maybe have better outcomes than we might have, and what negotiations and interventions do we have to learn from them to shortcut some of our needing to improve, you know, because we could maybe copy some of their models. And unrelated to that, a different question, is some of the staff training that we mentioned, and some of the, well, lots of aspects of staff training we've talked about today. And I wondered when I was reading here about, you know, the high number of agency staff that we have had to engage because of COVID and other factors. To what extent are the agency staff members fully up to speed in training? Because I imagine there's some emergency, so we hire some agency staff and they come in and work possibly more or less effectively, and that's the training aspect, isn't it? Because, you know, we have specific methodologies and protocols here, and it must be hard as a member of an agency staff to come in and be up to speed and suddenly apply the expected practices here. So having, you know, realised when I read through the high number of agency staff that must be a factor in terms of our outcomes, that they've been engaged and maybe not fully trained.
Who'd like to come in? It's Jennifer.
Change of voice.
Thank you.
Hi, so I will start with the agency staff and work backwards.
Okay.
I think I asked a lot of different questions, but I guess we employ agency staff from agencies that are on what we call a framework with the NHS, so they've been kind of, I guess, pre-checked, and the training requirements of staff on that, of the agencies that are on that framework would be given, so there are certain sort of statutory and mandatory training that all of those staff should have when they come to us. But then if they come to us to work in specific areas, yes, and I guess we've talked about restrictive practice and learning disability and other areas, if there are specific requirements over and above where we would expect our staff to have some bespoke training, then we will put that into place with those staff before they take place on the ward. And we've got various different services within the organisation where we've got a little training package that we'd expect people to go through to make sure that's sorted. So, you know, we do try, you know, we have assurance that people have had the training to the same extent as our own staff would have. We would expect that we do those checks through either HR or through ourselves, doing that additional support and training that we need for a ward basis. So I think we do have that assurance moving forward for agency. Did you want to come in on the agency point?
Not the agency, no.
Okay. Now I've almost forgotten what you said before that. It was about other organisations, wasn't it? Do you want to go on that bit?
Is that you, Brent?
Yeah, if I could, Chair. Yeah, I mean, there's a lot going on in that area. We're members of various positive practice kind of networks, obviously special interest groups, clinical kind of connections. But one of the key developments out of the latest, I guess, raft of legislative changes, which is obviously bringing the ICB on board, is the development of provider collaboratives.
Yes.
So working with other providers to think about solutions. So in this part of the world, obviously, we will work very closely with Cumbria, Northumberland, Tyne and Wear, but we're linked through that approach with other provider networks around the country. So there is a network of networks, if you like, coming together around that. We're also part of a collective for the North East and Yorkshire and Humber, where the Chief Operating Officers and the Directors of Nursing and the Chief Execs get together on a quarterly basis, and we share positive practice, challenges, various other issues. And there are a variety of other sort of similar things that we're doing. We'll also do that on a bilateral basis, so I can tell you that we're having a meeting with Surrey and Borders Trust in the next few weeks, looking at their community learning disability model. We're linking in with Hertfordshire Trust, looking at their use of seclusion facilities. So where we spot best practice, we proactively make those connections, but we are party to a number of different networks where systematically that information shared, so we can identify. And of course, through the department and through the NHS England, there are opportunities through Claire Murdoch, who's the National Director for Mental Health, where things are kind of circulated, and then they come through in guidance and those sorts of things.
Thank you, Chair. Could I just ask a quick question on the back of that?
Yes,
so
certainly.
The level of collaboration across the different trusts that you mentioned then, is it at the sort of executive level, director level, or does it happen at different levels of...
There's probably an opening of doors at that level, and then I think it's about really the people that do the work, doing the improvements.
Yes. But do the people who do the work also meet in collaboration as well? Oh, right, okay, thank you.
I've got Dominic first and then Dr. Spate after.
So firstly, I just hope I didn't appear disrespectful when I was talking about the restraint. It's an incredibly complex area, and I'm learning about it every day when I come into work. So I hope I didn't mean to sound disrespectful if I did.
No, I didn't interpret that, Chair. Thank you. I was just...
The other thing I want to mention was just on the agency element. What we do try and do, certainly within secure inpatient services, try and block book agency staff if we think we're going to need. So rather than just responding on a shift-by-shift basis, we'll try and block somebody for a period of time so they'll get the opportunity to try and build some familiarity with processes, with patients in the areas that they're working in. That's not to say that we're always able to do that, but that's certainly what we try and do. And I think the other thing in terms of our bank staff, an awful lot of our permanent staff are members of the bank. So when we are utilising members of staff who are working on bank, they're actually people who are fully trained in the work that we do and working within our services anyway. There are a number of people who aren't, but we do have a significant proportion of the bank that is permanent members of staff as well.
And Dr. Spade?
Thanks, Chair. It was just to give some reassurance about the working together and the levels within the provider collaborative for secure services. I think I've got 5 or 6 meetings this week within the provider collaborative, and I've got 2 this afternoon. So we since certainly the last 12 to 18 months, we're working very closely with the NTW certainly from a secure inpatient and forensic perspective as well. So it's becoming the norm now rather than something that's unusual.
Was there anybody had another question? I would like just to ask myself, when I was looking through all the metrics, I think there are some areas, and clearly the issues that have been raised today, and I was wondering if it was possible to have smaller sort of bite size rather than having huge presentations, maybe something after the November thing, if it's possible to have something about, say, the physical restraint, so we have a smaller, it doesn't have to be in person, it could be a sort of a presentation sent to us.
Yeah, thanks, Chair. I'm sure we can do that. One of the things I was going to suggest is obviously subject to the next presentation. You're presumably going to want to ask us to come back at various junctures. One of the things that we might focus on next time maybe use the clinical journey and the quality journey work that we're doing, which will get us into some of these areas as well as update on those metrics.
Right, that would be helpful. I think if other people would like that, I think, Alma, would you like to comment?
Yes, based on what you just said there, I think that's a really good idea. And maybe the way we work in future, maybe that we have a spotlight on a certain area for particular understanding more in depth on that topic in that meeting, rather than try and understand everything in depth in one meeting. So if we had a spotlight approach on the different things going through, I think that might be helpful to our understanding.
Yeah. I think the reason I ask is because when you get, say, for example, the about restraint, and when you're comparing, it's almost impossible to compare one trust with another or one care setting with another, because you'd look at it, and if you, when you're looking at generalised figures like that, you'd think, well, surely the target would include, you know, people with complex problems. But in actual fact, no one care setting has the same group of people, so it helps us. We look at them and probably feel really alarmed, and it might help to get the detailed information across, because we're not here to be shocked and sort of criticise. We're actually here to understand and help. And I think if we had something, and something that we could all agree on, or something that you're particularly interested in, I'm sure. I know you've got a lot on, but and I'm sure it wouldn't be burdensome, but I think it'd be really helpful. Were there any further questions on that at all? So we're moving on to our next rest of this. Have we got another presentation? I'm not sure what to have now. Yeah, hang on a second.
You have,
Chair.
Chair.
Report, yeah, that's it. So that's the right. So we've got the Tees and Eskin Weir Valley Foundation. It's the inspection update. So.
Indeed, Chair. If I may just say a few words at the beginning. It's Paul Murphy, Chair of the Trust. I actually want to say, because we haven't actually said this on the record yet, formally to yourselves and to the online audience as well, welcome to Rosebery Park Hospital. We're really pleased you're here. The team were really pleased. I gave you that invitation last time when we met on a screen, as you can imagine. I did perhaps underestimate quite how much work it was going to be to set it up, and I would just like to thank the team for their immense efforts in actually getting this to work. We were just particularly keen that you came to the hospital and that you met some patients and some staff and a wider group of staff around this table than just a couple of talking heads on a screen, because we think however many metrics and diagrams we give you, actually the real assurance comes from touching and feeling things and just getting a feel for the atmosphere, demystifying it. This is your hospital in a sense. It belongs to the community. We're but its custodians. It's a big hospital, 365 beds squirreled away around the courtyards here. It's bigger than it first looks. And what we are trying to do, and by we I mean everybody from Jen round to Claire, who's fortunate to leave to do something she just couldn't get out of. What we're trying to do is create an atmosphere where it doesn't matter if you're what grade of staff you are, whether you're a patient, everybody is able to talk to everyone else on a human-to-human level. And I hope you just got a little sense of that, even though we could only give you a glimpse of that today. We are going to give you now some more metrics and a presentation, having said all of that. But let me say once again, thank you for coming. You are very welcome. And I'll hand over to Brent.
Thank you. And just to reiterate Paul's comments, you're very welcome here. And if anybody does want to follow up on an individual basis with a further visit, then please do let us know and we can facilitate that. You're going to hear a little bit from me, but we do want you to hear from the people that have been leading the various activities and the key work. So some of our clinical leaders and operational leaders are in the room today to talk through. I'll just say a few words. If we could just go to the next slide. I'm going to talk a little bit around some of the work we've been doing on the strategic direction, our journey to change. I'll update you on some of the work that's happened since we last met in March. One of our colleagues, Sarah Dixter-Smith, is going to join us remotely. She would have been here today, but she's been unwell and is unable to drive this morning. So she's, through the power of technology, hopefully still going to be able to facilitate that part of the conversation, because that's a key bit of the areas that you were interested in last time. And if not, we've got a backup plan. And then, of course, there's the CQC action plan updates, which, again, colleagues around the table will talk us through. So if we could move straight into the next slide. You'll see this on the desk in front of you. Some of you will have seen this before. There are some new faces around the table, but I just wanted to, I suppose, put everything that we're talking about in context with, I guess, what we're about, what our purpose is. how we've decided on these kind of priorities that we've set out within this kind of very short document that we've kind of put in a visual format. For those of you that haven't heard this before, we very much embarked on this conversation, this journey with a conversation with thousands of people participated in an online discussion, in face-to-face meetings where we could facilitate them during the pandemic, and in various written communications, emails, letters, various other bits and pieces, to come together to think about how we could, I suppose, address some of the issues that had been running around the organisation for a number of months before I arrived in June 2020, and sort of, I guess, over the last few years, as we've been working through some of the challenges that we've faced as a trust. We've set out our journey to change. What it tries to do is to be really clear about what we're trying to do here as an organisation, as a trust. It sets out, importantly, our values and what we expect, I guess, in terms of everybody that has an interaction with us, that they can receive in terms of the behaviour and the approach that people will take in the way that people are dealt with. And it provides a clarity in terms of what we're here for, in terms of those three goals, three greats as we call them, about co-creating a great patient and carer experience, co-creating a great colleague experience, and being a great partner. And they're the three things. And where we've got to is, if we're not doing those things, then we're not really sticking to the plan. And a lot of the things that you're going to hear about today sit in the context of those three goals. And I think the purpose of, I guess, reminding colleagues, those that have heard it before, and putting it here today, is to say, well, this isn't about, no disrespect to Brian, it's not about the CQC necessarily, but clearly that is a big part of our thinking. It's not about ticking a box around compliance. It's about making care better. It's about improving the quality of what we do, and thinking about how we do that. And some of the themes that we've already touched on around engagement, how we embrace lived experience, the clinical skills we talked about in terms of restraint and various other things, but more importantly, the therapeutic input to the services that we'll pull forward, is about how we're going to move this trust forward. So that's really the purpose of just sharing that again. So if we can move to the next slide, thank you, Anne. Key achievements. I mean, as you would expect, there's been quite a lot of significant work done since March when we last met.
Excuse me, but could you just tell me what page we're on now? I've lost it.
So it's on the screen in front of you.
Yeah, I was trying to find it in my
and I can't. It is slide number.
Sorry about that.
1, 2, 3. Have you not got this in front of you? Apologies, colleagues. Yeah. So
It wasn't so
if you stick to the screens, Evelyn, then we'll make sure you get a copy of it afterwards. Apologies for that. I'm on key achievements and reflecting, I guess, on the work that's been going on since March, and what's been done since then. I suppose one of the key things, thinking again, about the report that was put forward by the CQC, thinking about some of the issues around well-led and governance and those sorts of things. One of the main things that we've done since then is we've implemented our new organisational structure. And if you recall, there were a number of key drivers for that. One was around becoming more of a clinically led and operationally enabled organisation. And the other thing was about simplicity and getting some of the complexity out of the way that we'd been managed previously and working through. I think it's fair to say that we've achieved that. We're on a transition, I guess, to getting those arrangements embedded. We've got our 2 new care groups up and running. We've got Patrick in the room as our managing director, and various other colleagues here who form a part of that care group. But one of the key things is that's been an organisation-wide change, which has involved all the different layers of leadership across the organisation. And now we have 3 clear tiers of clinical and operational management, and an associated simplified governance structure that supports that. And that's an important part of the change that we've made. The most important part of the change that we've made is the stuff that's kind of going on at the moment, where we're working through the organisational development aspects of this. We're thinking about the way that people need to be different with each other. People have referenced, as we've been going through, about the collective leadership aspects of what we've been trying to do. What we mean by that is we've put more clinical time into some of those leadership roles, and we're trying to get a balance of the different roles and responsibilities within those groups, so that actually everyone's got a shared accountability, which is explicit, that people understand, that they own, and that's a key way that we work through, I guess, the moving forward of the organisation, the learning that we do within the organisation, the interactions that we have with other organisations in the way that we want to take this place forward. Lived experience roles have been mentioned a couple of times. It's really good that the first one's joining us next week. His induction looks pretty packed, but that's really a reflection and a response to some of the things that we heard in the development of our journey to change, where people were saying, you're not listening to us, you're not hearing what we're saying. There are issues with the culture within the organisation, and what we need to be is more patient focused in the work that we're doing. So we've listened to that, and what we've done is throughout the work that we've been doing is we've been trying to reflect how we can build in lived experience roles across the board. We've used the phrase co-creation. That's a bit controversial in some areas because people go, well, what the hell does that mean? But actually what it implies is a bit different to co-production, which is what people talk about. It's about how we deliver the care, how we manage the care, how we reassure ourselves on the care, how we set the direction around our care. And what we want to do is to make sure that we've got the voice of people that use the service and care for people that use the service within each of those different aspects of what we're doing. Lived experience roles are a really, I think, positive step in that direction. That's going to change the culture. It's going to change the dynamic of the conversations that people have within the leadership world there. And they're supported by Sal Smith, who Councillor Hall's already mentioned, who's picking up as head of co-creation, who's going to look at some of the more of the corporate aspects of patient experience and how that's reflected in some of the policies and the procedures, as well as the complaints and PALS processes and various other aspects of what we do there. So there's a big commitment to that agenda as part of what we're doing. Conscious of time, I'm going to start to rattle on. I can feel people getting nervous. Board development and assurance. Board assurance. You know, we talked last time that we've been working with an outside consultancy and Deloitte, who have been doing some significant work with the board in terms of diagnostics and various other aspects, but actually really, most importantly, advising us and supporting us and coaching us in terms of the way that we work. So we've made some changes to our structures around the board, but actually we've spent some time thinking about how as a team we do that scrutiny and that assurance work, as well as, I guess, leading the organisation strategically. So I mentioned that the next point really in terms of the structural aspects, the governance processes, you know, the key part of the reorganisation has been about how do we embed that right the way through, cut out some of that complexity and move things through. A lot of that has been driven by our new approach to risk now. So we've completely revamped all of the risk registers so that we've got a really clear thread, again, from the shop floor through to the board in terms of the key issues and how that, I guess, informs our priorities around improvement, service development, you know, and those sorts of things. That's driven and supported by a now a very well embedded quality assurance programme of audit and various other aspects of kind of walkabouts and data collection and review, which forms a process that rolls out across all of our services. We made a reasonably significant investment last year to support this around practice development staff to be a part of that process, but to be on the ground to think about the continuous improvement of services using live, real-time, the data that's being played back through that quality assurance work there. We've been looking at the organisational learning infrastructure, and I think we did update you a little bit on this last time. The learning library, the organisational learning group, and a variety of other different activities that are going on across the trust which are engaging staff and thinking about how we communicate with people and how we can package up some of the key lessons that are being learned through various different routes so that we can inform practice as we go through. And we'll talk a bit about training later, so I won't dwell on that too much. Recruitment processes, again, we'll talk about, and that's been a significant factor in terms of how we recruit, how we have reduced the timescales on our recruitment processes and the rates at which we've been able to fill roles over the last few months. And you've been hearing a little bit, I think, today through your conversations about staff wellbeing and their experience. And I'm hoping you're picking up a bit of a sense, really, of where we are with the culture work. I think what I would say, Chair, you know, before I hand on to colleagues, is that we've achieved a lot in the last few months, but actually over the last few years, I think we've moved significantly. But what we recognise is that there's lots still to be done, significant amounts still to be done. But clearly, I think hopefully what you're going to hear today is really about how we're progressing through that. And I know that we'll be open to further conversations really about how we step forward on that. So I think that I'm going to hand over now to Sarah.
Yeah, just before you do that, Ben, I just thought it was helpful just to advise Scrutiny members that this presentation wasn't part of your reporting pack, but there was a comprehensive report as part of that.
Yes.
And this presentation just pulls out the highlights. So all that information and more is in that report, but we will have it circulated for your information. So at this point, I am going to bring in Sarah Dexter-Smith, who is joining us virtually. Afternoon, Sarah.
Good afternoon. Hi, can you hear me okay?
Yes, we can hear you.
Good. So I'm really sorry that I can't be there, and thank you to everyone for helping me get set up online this morning. As everyone said, I'll just whip through some of the key issues and things that I've heard as you've been talking. So if we go to slide 8, which is with the 3 coloured boxes, I just want to make the point that all the work we're doing around people and culture aligns around the National People Plan. That leads into the Board Assurance Framework, which is our 3 high risks that we've heard from the big conversation, etc. But then we're separating it out into things that we're doing as business as usual in the People and Culture team, and the things that we're doing underneath that through the Great Place to Work Programme Board. So there's a lot going on, and I'm just going to pull out a few bits for you. So on to slide 9, then, the recruitment and retention. Obviously, you can read that through the report and as you look at the slide, but just to talk to you about a few bits. So in the last couple of months, our data is much stronger now, so we're much more clear specifically where our issues are down to service level, where we're really strong. But overall, our vacancy rates, we're doing all right, actually, compared to comparable trust. People asking about benchmarking. We do that every time we get a report out on people and culture. And it helps us identify what the problem is. So our vacancy rates, we're on that all the time, as is every other NHS trust, but we've been better in terms of vacancies than other comparable trusts for the last 2 or 3 months. Yesterday, our staff sickness was at 6.6%, so we had 510 staff off, and 41 of them were COVID related. In terms of our recruitment, and we hear a narrative sometimes that Chuve can't recruit. Chuve do recruit. We recruit really quite healthily. We had an issue with the speed of our recruitment process. We've done a lot of quality improvement work. We've brought the Business Services Authority in to help us with the pre-employment checks. We've got new guides out for recruiting managers. And so our speed of recruitment is significantly quicker than it was even a month ago. We've got some ongoing work now with cross-corporate services, so that as someone joins us, we do our corporate processes much more smoothly, because people have to go through a lot of corporate teams for different things as they join us as a member of staff. The other question we get asked is, well, are you just cycling people internally, or are you actually recruiting? And about half of our recruitment is external, as you track that across the months. And we're recruiting more and more each month. So in April, we recruited 48 more new people, so external people, than we did in March. If we just go on to the next slide about staff absence, just to show you that. So we had a peak. I heard there was a question about January. January's Omicron was awful across the NHS, and we were no different. But we've come down quite significantly after that. We've had a slight peak, which I think is around the disciplinary process that we went through in one of the services, which you probably all know about, but that's stabilising out now. So if we go down to the Wellbeing and experience slide, so slide that starts about restructuring our People and Culture Directorate, we've recognised that what we did through COVID was, along with a lot of other trusts, was provided a lot of things to people and access to services. We're now having a period of consolidating that and regrouping. We've doubled the leadership centrally in the People and Culture team about health and wellbeing, and then we're doing lots of pieces of work, which you can see there, around what we offer to people who are in the trust, making it a better place to be. What we're getting a lot of feedback is it's not the things that we offer, although we know people receive them gratefully, but it's about the space to be heard and to listen, and then to get action taken. So at the bottom of the slide, the things around Schwartz rounds, the empathy training, the use of wellbeing hours, it's that we get really good feedback around, where people can come together, and we're giving that expectation that this is part of your day job, that we expect you to be able to have time to do this. If we go on to the next slide with the graphs then, just to show you that this all starts to tie together. So the things that we're putting our time and effort into is around particularly managers and leaders, and then our data insights. So we've got increasingly really sophisticated EDI data about patients. We'll have EDI data about staff in a really well analysed state by August this year. And that's because although we get all our EDI data, the denominators, the groups are very different. So you might have 1,000 people in one group and 50 in another. That's really hard to analyse. So one of our stats team bringing that together for us. But what people are saying to us is that, as I say, they're valuing the space, they're valuing being heard, but significantly, I think when we get onto the feedback, so if you go on to the next couple of slides, to the culture and staff feedback, what people are saying is that the staff networks are increasingly a place where they feel the execs are listening, we're giving them the time, but they can see change happening. And for me, that's the biggest shift, is that it's not just that the networks are there and people are able to come and share their experiences, but that the trust is listening and doing something about it. Our freedom to speak up work, last time you heard from us, you will have heard we were doing some quality improvement work on that. That's now much more rigorous and much more flexible. So that might sound like a bit of counterintuitive, but we've given people the freedom to investigate things as it suits the situation, but we're much more rigorous about tracking and also then triangulating. So we have a new speaking up group where people across corporate services and operational who go in and out of teams, we get together once a month and talk about what are our rumblings, where are we concerned about before it hits any data points. And that's been really useful to start to pick up concerns that are sort of starting to bubble across different parts of the system. And then if we just go on to the pulse feedback. So just to say about this, our staff engagement rate is 29%, that's fairly consistent. That's not brilliant. You know, I'd much rather that was much higher, but equally, you look at what's the issue there. We were the second highest in the North East North Cumbria of the trust that responded to the question that went out. So we've got lots more to do. Things like our, people are reporting feeling that they've been bullied or harassed at work has come back down significantly, so in line with or below the national average. So again, we don't want that to be there at all. We want to be at 0, but all of these trends are starting to go in the right direction. And some of our data is starting to pick up a little bit in the pulse survey. So things like, would you recommend working here? Feeling the trust is prioritising patients or clinical services as a top priority. The next pulse comes out in a couple of months, and that's the one that I really want to have a look at, because that will be, we'll hit the lag of the things that we've put in place at the start of this year. I won't go through the next slides because they're just feedback from staff that you can see. But they're just feedback around things that we've done around lunch and learns and the staff networks and the monthly coffee breaks. So we have a monthly session every month that everyone can come to and just talk to us about what's it like to work here and either get answers or flag us things that we need to pick up for them. But I'll stop there because I can see you needing the time.
Thank you very much for that, Sarah. I was just wondering if anyone has any questions at all? Brent, would you like to?
If we can, we'll move on then to the next bit, if
Certainly.
that's okay, which is the response to the CQC action plan. I think colleagues, it's Dominic up first.
So in keeping with colleagues, I'll try not to spend too long in terms of going through the slides. So just as a reminder, in terms of the secure inpatient service, in terms of some of the key features and areas of focus that were identified in terms of the inspection that took place in June of last year, key areas of focus were around staffing, were around safety and safeguarding, and also around the governance systems within the service in terms of ensuring quality and safety. So in terms of the staffing elements, I just want people to be aware that we've implemented and are utilising a system called SafeCare, which ensures that we're safely staffed on a daily basis. There are 3 formal meetings per day and a duty nurse coordinator who's available within the service at all times to ensure that we're able to flag and address any staffing issues as they arise. We've also introduced, in terms of, you've already heard about engagement and about culture, we've also introduced, and I've got a colleague with me, Helen Day, who's worked hard on this, a healthcare assistant council within the secure inpatient service. The healthcare assistants obviously form the largest part of the workforce within the service, and traditionally when we look at our governance arrangements, their voice has been very much at a ward level. The Healthcare Assistant Council has given healthcare assistants the opportunity to contribute and shape the service throughout, in terms of all levels, in terms of the leadership structure. And in terms of my experience of that and engaging with the Healthcare Assistant Council, it's been, I use the phrase gold dust, and it is gold dust in terms of the information that we're getting through from that particular area. Ward improvement groups have been established across the ward areas, and also the Secure Inpatient Service is now part of a broader fundamental standards group across the care group. And the reason I've put that in, as I think it's really important from a culture point of view, that whilst the Secure Inpatient Service is a specialist service, it's still important to be engaged with broader services around it and to be able to kind of not only learn from those services, but also offer some of their learning to those other services as well. Patient colleague experience is something that Sarah's described, and also some of the key areas that were highlighted in the last CQC report were around access to activities. The work that's been done within the Activity Hub is significantly enhancing the range of activities that are available to service users within the Secure Inpatient Service, and that has been helped by some of the relaxation that we've had in terms of COVID restrictions. So in terms of the number of patients who've been able to access that space and activities at any given point in time. We've also continued to try and recruit activity coordinators. That has been more challenging. So the activity coordinators complement the work that takes place within the hub. And what we've done is, in terms of the numbers of activities coordinators we've been able to recruit so far, they're very much ward-based, and what we've done is we've identified the areas of kind of highest acuity and highest challenge for activity coordinators to be based there in the first instance. But I think we're just on the verge of being able to have an activity coordinator allocated to each of the wards, so that's really positive as well. Sarah's described recruitment as a challenge and some of the steps that have been taken in relation to that. From a Secure Inpatient Services point of view, that still very much is an issue for us, and I think particularly from a registered nursing point of view. So I don't want to make any bones about that. I want to be open and transparent. And we've managed to recruit in terms of areas like our healthcare assistants. That's moved positively forward. In terms of one of our colleagues has had to leave because actually Claire's gone to interview a psychologist today for a consultant post. So we're seeing growth across allied health professionals, etc. But from a registered nursing point of view, we are seeing some challenges there at the moment. We have some international recruitment, which is moving forward in terms of support with that. And we also have a number of preceptors who will be coming to join the service in September time. And the other thing from a staffing point of view I just want to highlight is the induction process that we've put in place for all new staff coming into the service, which is a 2-day full induction, which enables a much more detailed focus around the work within the Secure Inpatient Service, as well as ensuring people have access to all of the training that they need. It's a 2-day induction specific to the service, but also on top of that, there's the training that staff need to be able to work within the service as well, in terms of some of the issues that we've described in terms of positive approaches to challenging behaviour, etc. On this slide, what I'm describing, we've kind of touched on training, we've touched on culture. On this slide, what I just wanted to highlight is, I think, a link that you've already been sent, but the service has produced a film in conjunction with the production company, and going back to that principle of co-creation, it's absolutely being co-created with the service users within the service, and describes what a service user experience is of living within a Secure Inpatient Service, and that is now forming part of both our induction processes but our ongoing training processes. And just to give you a very brief taste of that, I think we've got access to a 60-second clip to share with you.
Hope is such a small word for such a big important feeling. Hope to me, it's something deep in all of us. And remember, if you're suffering, extreme pressure forms diamonds. That's hope, a diamond. In each of us, they're indestructible.
Hope is seeing change and knowing it is possible.
Hope is the invisible thread between your heart and mine. It's like magic.
Hope is seeing the ripples take effect. It's knowing you're part of something bigger. Hope is laughter, friendships, and trainers.
Hope is beginnings and endings, and celebrating the journey.
It's my people, my family, my diamonds.
Hope is determination and grit. It's not about never stumbling, but about continuing your journey and carrying on.
Hope is having new adventures. It's about pizza with friends.
Hope is dancing over the border, looking back at the road you've trod in your bright red trainers. It's saying goodbye and looking forward.
Hope is recognising the value you offer.
Hope is community.
So that's an incredibly powerful piece of film, and I don't know anybody who's seen it who hasn't been impacted by that yet. So again, that's an absolute core part of the training induction processes for services and people working within the services. Moving on to the next slide, from a safeguarding safety point of view, again, our safeguarding level 3 training compliance has increased to 95.98%, which is above the standard that we've been aiming for. We've offered over 50 formal safeguarding supervisions since November of 2021. That will have increased again because that figure's pulled from kind of end of April's data. And there's clear evidence in terms of impact of that, in terms of the number of safeguarding concerns that are being raised and discussed with the internal trust safeguarding team. So that for me, that's highlighting that staff are more observant, staff are more inquisitive in terms of the area of safeguarding. As a result of those conversations with the internal safeguarding team, reassuringly, that's not translating into increased referrals to the local authority. But so just to give you a sense, some of the types of conversations that are occurring within the service might be around what staff have observed in terms of a patient-to-patient interaction. It might be what staff have observed or become aware of in terms of technology is a double-edged sword. You know, it's great that people have access to that to communicate, etc. But sometimes that can leave people open to financial vulnerability, etc. So they're just some of the types of things that people are raising and discussing with the member of the corporate safeguarding team who's been based with the service. And again, I think in the earlier slide, there was it was referenced that we have introduced human rights training, and in terms of that human rights training, 93% of our staff are saying they'd recommend that. That's really important. We put that alongside something called boundaries training, and that's really important in terms of supporting some of the understanding of restrictive practices and restrictive interventions, and introducing that much more kind of rights-based approach to care. That's not to say we don't have more work to do. We absolutely do, but we're getting some positive feedback around that in the first instance. From a governance point of view, we've introduced a new model of care and professional practice, and again, Helen and Claire, unfortunately, have driven a lot of that work. What that's describing for us is the therapeutic environment that we're trying to create. It's also describing the types of interventions, and importantly, the staff training and the staff development that needs to sit alongside that. So when we talk about culture, we're trying to locate it all within the model of care and professional practice. And picking up on Brent's point earlier on, in terms of all of these improvement actions, we're trying to make it about the service. We're trying to make it that it's about the service users and the staff who are within that service, rather than trying to satisfy regulatory requirements. That will come if we get the other elements of it right. And as part of that, increased visibility of service managers and modern matrons. One of the challenges within the service was that a lot of things were being managed at the site-wide level. We've introduced smaller pathways or groupings within the service and leadership groups that are allocated to those groupings, and that's building kind of the awareness and the familiarity and the comfort of kind of staff who are working within the wards and patients within the wards with their immediate leadership teams. Also supporting with minimising the movement of staff to unfamiliar areas. So absolutely clear that one of the concerns that has been voiced by our staff and also by the CQC was about staff who were being moved to different ward areas and who didn't feel comfortable within those settings. So again, the work around introducing pathways and groups has meant to absolutely minimise that. And as part of that safe care process, we've also introduced a red flag if somebody gets moved to a pathway outside of their normal pathway, so we can go back, we can have a look at that, and we continue to monitor and try and improve our performance against that. Increased staff wellbeing activities and launch of a CIS wellbeing group, and increased staff and patient wellbeing activities. So we've recently had a patient within the service who's qualified as a physical instructor and has been running circuit sessions for other patients and staff joining in as well, which is absolutely fabulous. We've got events planned in later on this month. There's a 5K within the perimeter there's walks, etc. And then importantly, we're also reviewing, I mentioned already the issue that one of the areas that we're still learning about and still kind of trying to develop our approach around is around technology, and what challenges and benefits that brings, and how we balance that in terms of both for patients and for staff within the area. So it's absolutely an area that we're looking at, and we know we'd had feedback from staff in relation to having access to their mobile phones because of the length of shifts that they do, in order to retain contact with family and home if necessary. So we're exploring, and we're on the verge of introducing an area within the perimeter where that will be possible for staff. And we're also reviewing and individually assessing patients in terms of access to their own smart electronic devices as well. Next slide gives a bit more detail around the model of care and professional practice, but I'll let people have a look at that, and happy to pick up any conversation in relation to that. And then the slide after that, again, is just a little bit of staff feedback, which again, people can have a look at and in their own time. So I'll stop there, and again, take any questions if that will be helpful before we move on, and I'll pull in my colleagues Helen and Mark in relation to that.
Have we any questions from anyone? I'd just like to ask, actually sort of the last point, when you've got staff who are doing 12-hour shifts, it's important to keep them connected, because it feels like a little village here, and when you come into it, it's sort of otherworldly. It's almost like you've left Middlesbrough and the surrounding areas and come into in a nice way. But I imagine if you're working here for 12 hours, there's the concern that, you know, what's going on in your own life. And I know some people like to have the 12-hour shifts because they get their blocks of work out of the way, and it's quite good for their work-life balance. But I think features like that to improve the quality of the environment for staff is something I'd welcome. And I think, you know, the sort of environmental enrichment, even when we're walking around, you know, seeing things that look like they come from the outside world, hearing that you have ice cream vans and things in, that helps. So, you know, it's interesting to hear about these things. That's just a little observation from myself. Alma, did you want to?
Yes, thank you, Chair. Just going back a little bit to what you were talking about, Brent, this lived experience whole idea. I don't think we need to have it in detail now, but I'm very interested in more detail about that particular aspect. For example, how new is the notion? How do we collect the data? What's the training for this? How are we recording it? How does it progress? So that lived experience model, maybe I'm naive and everyone else knows all about it, but I felt that I'd be really keen to know particularly more about that lived experience terminology and definition. Thank you. It might not be now. I'm saying maybe we could send it.
By all means, we could maybe do that at the next session. And Paul's just whispering to me, perhaps we bring Chris along to the next session. If that's something that would be of interest, and you can get a sense of what they do and how it works. It's relatively new.
Oh, it is new, yeah. I thought it might be. I didn't know if it was just I didn't know about it too much.
Yeah.
But
I mean, we had peer workers for a while and those sorts of ideas, but this is a different approach.
So I'd be interested. Thank you, Chair. I appreciate that. Thank you.
Anne, would you want to?
Chair. Acknowledging the difficulties of security, when you're looking at leisure, which people locked up need, what about gardening? You've got some lovely gardens there. Do residents participate in that? Artwork?
I'm going to respond to that one, because, if I may, taking over from my colleagues, because I've spent a lot of time with the gardeners in the secure service, and I mean they spent hours showing me proudly their polytunnel. There's a whole microeconomy going on in there, because some of them are growing plants from seed and then selling them to the other wards. And they gave, it's all above board, yes, please, you know, so it's all, but I mean, I hope you've seen that the grounds are actually quite pleasant, and they're getting better all the time, and a lot of that is down to the patients, and we've got some really keen gardeners amongst them.
Within the patients?
Within the patients, yeah, the patients who, my last visit, laden me with plants to take home, so I've actually, you know, came out through that airlock with plant pots, because it's a really heartening way. It is important, and yeah, and one of the reasons we wanted you to come here is to see that in its own way, quite a pleasant environment, and the patients play a key part in that, I can assure
Yeah,
you.
I was going to say it was pleasant when you come in, but as long as the patients can interact with that pleasant
They
environment.
do. I mean, they're in charge of it, to be perfectly honest.
Brilliant. Thank you.
Chair, can I just add
Yes,
something to that as
certainly.
well? I think one of the things that we experienced, as we all did within this room during COVID, was that a lot of our community links were restricted significantly. And what we've seen over recent months is a real increase in the number of service users interacting with activities like the one you mentioned, Councillor Watts, in the community. Some of my gentlemen go to gardening groups that are beginning those in the community that have been linked by our occupational therapy team. So we've seen quite a significant change in people's access and the things that they can do. I think it's our business really is transitioning people from an inpatient service into as independent a life as possible in the community, and you don't go from one to the other without there being quite a bit of work in between. So it's about getting that right, and like the removal of COVID restrictions is kind of really helping with the opportunities that come available to people. So I think we're starting to see the changes in that, and I think over the next few months and the rest of the year, I think we'll really see an impact in that way.
Thank you, Chair. That reminds me of something else I was going to ask about earlier, and maybe again we could have feedback later on this. It was the notion of education overall, because I noticed in the activity area they have education, and we were told education, but I just wasn't sure what we meant by education and what that means. So, you don't have to answer me now in detail, but I just wondered, what does education mean in this context?
Just to give kind of feedback with the service users that I work with, it's access to teachers to develop English skills, math skills, computing as well. So I think that in the longer term, but based on the point I just made, it's about what we'd really like to do is develop those links with educational establishments like in the region. We've had people go out to places like Middlesbrough College and various voluntary organisations to do activities to gain qualifications as well over time, but they seem to have been on like case-by-case basis, and that has been affected by our own access to the community as COVID. But I think that we would welcome as a service those links with local providers, and we'd be more than happy to have those discussions if local providers felt that that's something they could help us with, particularly with the colleges.
Thank you, Chair. I think that's a really interesting dimension that could be pursued where appropriate. Yes, thank you.
Did anyone else have anything?
I was quite encouraged by listening to this. I think it's reassuring that things are going on, and I'm pleased to see a lot of the work going on. I am concerned still that getting registered nurses and this sort of thing is still a challenge. And I'm interested in the safeguarding supervision that you're really stepping up with. I still have my concerns about what's gone on with the metrics and things like that, but I do find it encouraging, and thank you for that.
Anyone else like to ask a question at all? I think, any more comments, or would you like
If we could just move on and just cover the children's services. We're conscious of time,
yes,
but obviously we'd quite like to tell you about that.
Yeah.
Okay, thank you, Chair. I'm taking the children's services
Thank you,
part,
Jennifer.
and I've got my colleagues Kathy and James who are sitting beside me, and that we're going to do a bit of a triple act perhaps we've only got a couple of slides. So I guess just to start off then, this is our, I guess it's the point of the presentation is an update on the CQC action plan, so that's what these slides are focused on. However, what this probably doesn't give you is a flavour of all the transformation work that's going on over and above what we're going to tell you today. And I guess just going back to your point before about having having some slots in future meetings, we'd be more than happy to come and do a bit about CAM specifically, about what's going on across the system, particularly in the Tees Valley area, or to come to any different meetings. We'll be more than happy, so please just ask and we'll be happy to come and do that. We've already got some invitations in the diary, but not for all of the meetings, so we'd be happy to do that. So the 5 key areas that we're concentrating on as part of our CQC response. Sorry, my eyes are not... I can't put my glasses on for the screen because I can't see it, but I have to put my glasses on for the laptop, so I do apologise. Not quite right for my eyes. So it's looking at the keeping in touch process, the waiting times of children and young people's, staffing levels, caseload management for our staff to make sure that they haven't got too many cases to manage at the time, and staff training. So they were the 5 areas, I guess, that CQC had brought up, and they're the 5 areas that I'm going to concentrate on for this presentation. Next slide, please. So the first slide I'm going to do, and then I'm passing over to some colleagues. So this is just some headlines about where we're at with those 5 areas, really. So we have introduced a keeping in touch process, and this is in relation to making sure that children who are on the waiting list for treatment have got that sort of contact, I guess, with staff in the service to make sure that if they have any anxieties, if a family or a carer feels that the young person is their needs are deteriorating for whatever reason, that they know who to contact and when, and we've got the processes in place at we have different timings. That's how often we keep in touch depending on the needs of the young person who comes into the service, and that, without giving you too much detail in the background, and I think it's in your pack anyway, but the needs of the young people are kind of rated at the point of them coming into the service, about whether it's low level, medium or high level need, and depending on that will be how often that we keep in touch. And obviously people who are seen as urgent, so just to give you that reassurance, people who are urgent needs, they will be seen straight away, so they're not the people that we're talking about particularly in this process. So we know as of whenever we pull this slide together, which is in the last couple of days, that 97% of children who are on our current waiting times have been kept in touch with, in contact with, within the timescales that we've stipulated. And just to give you a little bit of context of that 97% of children on the waiting list, it equates probably to about 3,500 children. So it is a bit of work to do, but actually we've got a system in place now electronically, which is in the next bullet point, which helps us do that. And we also have a daily huddle, so Monday to Friday at 12:30, yes, 12:30 or 12 o'clock, I think it's 12:30 every day. We have a huddle with the team managers and the service managers of the CAM service across Durham and Tees Valley, and we all come together with our numbers, and we have people from our corporate services, and we just make sure that everything has been done. And if there are any anomalies found, because it's a moving picture every day, because people come on and off caseload, so it's never the same number twice. But if we see anybody that we don't think has had a letter or hasn't had that contact that they should have had, then we pick that up straight away, and it's rectified within 48 hours of us knowing that. So we've got a really good system in place, and we're working on getting that better with more and making it more electronified, which is not a word, but I've just made that up, but you know what I mean, having it more on a system. It is on a system, but we're going to get it better as our systems improve. We're working with our staff in IT to do that. Recruitment is still an issue, if I'm honest. Again, a bit like Dominic has said, for secure inpatient services. We are struggling also to recruit registered nurses, but we are trying really hard and trying more creative ways of doing that. You know, just to be clear, that I don't think that's just a TUV issue. I think it's just an NHS issue at the moment. So we are looking to recruit where we can, and if we can't, we're looking at different roles and different ways of filling those roles. So that is a big bit of work that we're on it all the time at the moment to try and make sure. We do have different levels of vacancies in different areas, and I do think, although James might contradict me, but I think Tees is slightly healthier for staff than the Durham end of the Durham Tees Valley patch at the moment. We're probably carrying more vacancies in Durham than we are in this end of the patch, so that might give you some assurance that recruitment has gone better lately in Teesside. We're working with staff, engaging with staff across the service to look at how we help to manage the caseloads. We do know that some staff have had traditionally carrying quite high caseloads, so we're doing what we're undertaking, what we're talking about caseload cleansing, I guess, with all of the teams. We've got a plan in place for which team we're doing where, so this is across Durham Tees Valley, and it also covers North Yorkshire and York at the minute, because we're looking at the service as a whole within the trust. But the plan is to have that caseload cleansing finished to all teams by September. It takes a little bit of time to do it properly, and then through that we're then looking at what resources we actually need, because I think until we really know and get people's caseloads settled down, we don't know what kind of staff we need in which teams, and it won't be the same in any two teams. It's going to be different. So some teams we might need more nurses, some teams we might need more psychology staff, some teams we might need more people who work to do family therapy, other type of skills. So that bit of work is going on in tandem. So it's going really well, and I think it's been quite well received by the teams that have gone through that so far, and has made a big difference to people's work-life balance, which is really important, isn't it, to make sure that we get people in Because I guess some of the issues that we may have had before, and again, not just CAMS, is that people get a bit overwhelmed with life, and that might be why they move on and choose to work somewhere different. So we want to make sure that that's as good as it possibly can be. We've talked about the huddles, which is the last bullet point there about monitoring weight, and we have 5 times weekly huddles to monitor that, but actually the senior leaders in the service also look at training compliance and things as well as that, because that was another thing that was picked up with our report, is about stat and man training for staff and how that's working, and that has increased significantly in the last few months. We put a real focus on that, making sure people have done that. Some of that was due to COVID and people not being able to attend training not being on, but we have absolutely stepped it up, and we've got quite a lot of e-learning, so it's about freeing staff up to get that done, so we have made an effort to do that. And then just the last bullet point from me, or the last bit in blue on the bottom there from me, and I'm going to pass on, is just about, we did an anonymous poll to our staff, and within the sample of staff that replied to that, 86% of those staff feel that they know where the service is going and they think that it's going in the right direction. So that was pleasing to note. However, since that survey was undertaken, we've done some more engagement sessions. We've got another one this afternoon, I believe, and we've had about 700 of our staff through those engagement sessions. So it's just about making them understand where we are and where we're trying to get to. It's not going to be a quick fix because of recruitment and all of the challenges that I've discussed, but actually they can see where we're going and why we need to get there and how we're going to do it together, and making staff feel that they're part of that plan, and it's not just a top-down approach. So I'm going to stop there and I'm going to pass on. Is James going to next? Yes. So, yeah. Can you see? We're all...
I'll go
James has got younger eyes than me, so you can see the screen. Thank you.
Hi everyone, my name is James Graham. I'm the recently appointed General Manager for Durham Tees Valley CAMS, but prior to that I was the Head of Service just for the Teesside CAMS. And prior to that I was actually involved in commissioning of young people's mental health and emotional wellbeing services for Tees Valley, so I've got a bit of history on this agenda. I think what Jen's just talked through there is really some of the quick actions we've put in place on the back of the recent CQC report to really get some quick actions and impact on the back of those concerns, but then we also need to think about, well, how do we sustain that in the years ahead? And really how we do that is through a transformation process, which I'll try and briefly describe to you now, and that's all about having a whole system approach to meeting the needs of our population. So it's not just CAMS services are obviously a big part of that system, but it's working in partnership with everybody right across the whole system in social care, education, other providers. And to do that, we use this framework called iThrive, which is it's a mandated framework nationally. It's one of the ones that's recommended as part of the kind of NHS long-term plan for improving children and people's mental health and emotional well-being nationally. And what that kind of helps us to do is how coordinate and plan all the services available in the system, so we've got the right amount of each types of those services in the right place to meet the needs of the young people. So using that diagram there, it's based on national sort of evidence and methodology, and 80% of our children and young people are all emotionally well. They sit in that yellow bit in the middle. That's about 80% of our 5 to 18-year-olds are in there, but they will benefit from preventative programs, training to help keep them well. The adults in their lives, their carers, the teachers will benefit from training to help keep them emotionally well, so we need some services to do that. The top 2 quadrants is where, so the rest of the 20% of the population who have some sort of mental health and emotional wellbeing need, 90% of those actually sit in those top 2 quadrants there, who have what we would consider to be more mild to moderate mental health and emotional wellbeing needs, and they would benefit from some advice, again from training, maybe to them as young people or to the adults in their lives, might need some training to help manage their emotions, manage their environments better, and those in the blue quadrant will benefit from a period of evidence-based interventions. Now, historically, all of this demand has tended to come into CAMS services nationally, and the bottlenecks have happened, capacity and demand issues, and what we're starting to see now, and Teesside is actually quite advanced with this, is we've got a lot more going on in the rest of the system with some other providers who are now helping, or working in partnership with us to meet a lot of that demand for those 90% of young people with a need. The other 10% of the people with a need you would expect to be more complex ones who will need to see a consultant psychiatrist, might need some medication, would need some risk support. That's typically your specialist CAMS services. And by putting more in place for those green and blue young people, those capacity demand issues we see in CAMS historically will improve and will better be able to meet the needs of those more complex and enduring cases. And we're really starting to see some good improvements with that, particularly in Teesside, as I said. I think we'll leave that there. Next slide.
So I'm Cathy Byard, so the CAMS Specialty Clinical Director. I'm a psychologist as well, and I did work in Stockton until relatively recently, when I've moved to North Yorkshire. So we've done an internal restructure of T's CAMS to align against the iThrive framework because we knew that this was the way forward, and we've actually worked with our system partners to help support that and think about it. So in that blue quadrant that James was talking about earlier, certainly Stockton Hartlepool, you've got quite a different approach where it's another. This is where he finds out his phone's not right. So typically getting help in some parts of our organisation, those are clinicians who are employed by us, but actually Stockton Hartlepool, it's clinicians employed by one of our colleagues at the Alliance, and we provide the supervision of the supervisors. So we're very closely working together, but it's just made a brilliant seamless approach for young people and families. So you know, that's we're kind of taking a bit of a lead on that. It's unusual. We've looked at that senior leadership, senior clinical bit to improve quality. We're wanting the system to be more flexible and responsive, and thinking about the voluntary sector, third sector. We've had lots of discussions over recent years thinking about whole pathway commissioning. Really more recently we've been talking with the Director of Children's Services, and between the 5 areas, Durham, Tees Valley, so Darlington and Tees, it's been agreed, so Martin Gray, Director of Children's Services for Stockton, has met with all three, the 3 of us, and also the other providers, and we're really starting to think about piloting an integrated approach to see if this makes a difference. And we're going to share learning. Interestingly, as part of a wider organisation, CAMS overall, that's also happening in other local areas. The bit about me and my role is I can get to have a bit of oversight of that, and I can bring learning into what we're all doing together. Really wanting children, young people and families to get that flexible access to service. Talked about the getting help numbers, and we're starting to see a real reduction in caseload numbers. And the other bit to just let you know about is the mental health support teams in schools. So this is a real push and a drive, and I think we're going to get about 50% coverage by this September.
By the end of 22-23.
So this is a mental health support teams in schools. It's a 12-month training programme. So the cohort that will start this September will then, by the end of next year, we will get the 50% coverage in Teesside. And those are clinicians who absolutely, you know, children, if they're going to school, that's where they're seen most regularly. Part of our meeting with Martin Gray was we had some head teachers from the mental health support teams, and they were describing how, you know, these are head teachers, they know these families really, really well. It's much easier to have those conversations about, I'm just a bit concerned about, you know, Cathy, she's struggling a little bit. And it's easier for a family to talk to them, and then we can come in, or our colleagues in the BCS or in the other getting help services can come in, and we work together to support. So that's the idea of that. It really is a brilliant, and it's something I've been talking about for years. It's a brilliant add-on to what we're providing. So that's what we're doing in terms of thinking about the iThrive and working together, and we'll pilot. I don't think that probably north of Tees we were thinking, but it hasn't been decided, but we will be piloting, we'll be doing that with Martin Gray, to really just take our learning forward. And the only other bit I was going to add in was, I don't know if any of you have seen the report, Health and Social Care Leadership Report. It was out, it's been across all the news this morning. This was my interesting breakfast reading. But just some of the bits there that are kind of coming out about leaders in health and social care. and I really did just scan it, but it's talking about having engaged, motivated, committed staff. And the bit that I think we're trying to do, not just in CAMS, but I think as an organisation, is absolutely what's coming out in that report. So if you do have access to it for your bedtime reading, I suppose just some of the strands, actually, we're on it. We're still not there. We've got still work to do. But it just feels a little bit like we're getting there. We're in the right direction. That's me.
And Chair, that is the last input we're going to make to you. You'll be pleased to know. And so, there are any questions?
Yes,
please.
I'll just.
But then we will move you on to lunch. Just
right,
to remind you that.
So, did you want to start us off?
Yeah, thank you, Chair. I just wanted to add, on behalf of the governors, just to reassure the committee that in everything that's gone on, journey to change, etc., governors have been consulted, informed right from the beginning, and on our Council of Governors, it's made up of service users, carers, staff, people who are passionate about mental health who have been elected by the members. So it's really representative of people. It's not just people like myself. I'm nominated from Stockton Borough Council, and of course there are other councillors on it. But the majority are people who are passionate about mental health. And we are, I refute what was said at the beginning of this meeting. We are involved. We have been involved right from the beginning. And I can't fault that at all. And I would hope that you would accept that, Chair, because it is true. And I just wanted to add, although we're focusing on Rosebery Park here today, the trust is more than Rosebery Park. The Council of Governors covers the whole of the trust, from West Lane, Scarborough, Lancaster Road, you name it. And we as governors always like to be reassured, and it's questions we always ask. If there's best practice in one area, prove to us that you are sharing that best practice. Because I think what was said at the beginning, that I am Stockton's lead governor. I am not Stockton's lead governor. I am the lead governor for the Trust, Council of Governors. And just with another hat, if you permit me, Chair, I am chair of a little school in quite a deprived area that was one of the pilot schemes in High Clarence. And honestly, that has made a huge difference, and the legacy of that pilot scheme has sort of still been there with the teachers, helping them with the day-to-day problems of some of the young people we have in that school. So, forgive me if I just interject that, which is with another hat on, but I just wanted to reassure you that we as governors have been involved from day one.
Thank you very much. That's a very useful interjection. Thank you. Appreciate it. Alma, did you want to ask a question?
Yes, thank you. Yeah. Just picking up on what you said there about schools, I'm really very keen on this mental health support teams in schools initiative, since I, like you, am in various governing bodies in schools. And I mean, I know that you talked about the increased provision of the service, but the demand is greater, isn't it, on the ground because of COVID and all the rest of the circumstances. So although, there's increase in capacity, there's also increase in demand, and I'm not sure to what extent that is in terms of the depth of the problems of the demand. And that made me think also in that general aspect about, this is the new look CAMS, if I can call it that. Have you advertised this new look dimension to schools? Because when I go into schools and other organisations, people talk to me about CAMS, and the bottleneck that you mentioned is often referred to, and I think people give up hope and look elsewhere. But if we've got a new look service, I'd be interested to know to what extent you're letting the general public out there know about it. And my other question was about looking and working with other providers that you mentioned, and working in this different way. Has that been a financial constraint, or have we got more finances in, or is it reconstruction? So it was about finance, really, the other question.
We'll go backwards again, because I'll do the first bit, and then James can do the bit about the schools, because he'll know a bit more about this neck of the woods than I do at the moment. I guess in it's not a financial constraint. I guess what we're seeing, I think you've already alluded to, is the increase in demand,
Yes.
and particularly the increase in demand in lower level
Yes.
needs. And I guess the difference is, I guess, it's a difference between, it all gets badged as mental health, doesn't it? Because that's the term that everybody uses. But actually, this is a secondary care mental health service. People will have problems with their mental health that don't need to be referred into this type of... It's a bit like you could be unwell, but you don't necessarily need to go to hospital. You could be seen by a GP or seen by somebody else. And I guess we are trying to sort of just forge those links with other people out there who can provide that much more quickly and efficiently than we can, because our resource is commissioned for that secondary specialist mental health resource. And I think what's happened is, over time, because it's been on more people's radars, it's become, you know, more people are being referred in, and then COVID, so all of those things that you've alluded to just means that we've had a bit of a tsunami into the service, which means within the waiting list of the children are probably children with more significant needs that are not getting seen as quickly as they should because of all the people with the lower level needs. And it's not that they don't need to be helped, because they absolutely do. It's just them going to the right place at the right time. But I think going back to what James said in his slide, you're doing really well on Teesside, so you might not feel like you are, but again, it's that benchmarking, isn't it, about if we could show you how, you know, the infrastructure in Teesside in those other organisations is far more advanced in Tuve than any other of our, you know, more advanced than in Durham, more advanced than in North Yorkshire and York. And then we've obviously got benchmarking outside of the organisation as well. So you're actually doing really well, and you're quite far ahead. It might not feel like that on your side of the table, but that's for us to tell you, which is what it might be nice to come and do a special session on CAMS at some point. James, did you want to talk about the school coverage? Because I don't know how, I know that in the Durham end, which is where I've come from before our rules changed in the restructure, so now I'm covering the Durham and Tees Valley bit for CAMS and LD services. In the Durham bit, schools could put themselves forward to apply, so it was who wanted to be part of the first wave of the mental health support team. I don't know if that was the same in the Tees Valley, so I don't want to assume.
It was slightly different, and it's a different delivery model. So those mental health support teams at schools in County Durham are in the main provided by Tees Escamillia Valleys, whereas in Tees Valley they're provided by a consortium of third sector and voluntary care sector providers who were all working in partnership with us as well to do that, and we do think it brings a bit of additional value, really, because they've got all sorts of links to other community initiatives and social enterprises, and they get all sorts of different funding that they're eligible to bid for, which just enhances the whole offer. And actually it's going to enable us to probably get closer towards that 100% coverage a lot quicker than the national kind of mandated rollout, if you see what I mean.
And just thinking when you were talking about the model and getting it out there, this is a fundamental system change. I mean, it's brilliant. It's what we've needed for CAMS for years. You know, specialist CAMS don't hold. We don't have all the therapists. There are people out there that can do the work. But I think to get that change, it's going to take a little bit of time and relationships. And we've done lots of work in terms of thinking about whole pathway and working with colleagues. But still that message doesn't quite land. And that's because it's such a big change. I think now the focus from the Director of Children's Services, and it isn't just in Tees Valley, but that focus about now we need to pilot something different. And people start going, oh yes, and actually even in our recent meeting a few weeks back, the head teacher, suddenly there was that kind of dawning, oh, I understand it now. And you think, yeah, so we just need to keep selling the message. We keep needing building the relationships. We need to keep saying that we're working with you. We're starting to get some young people now coming through that are now starting to also articulate that message. So it will happen. I'm absolutely determined it'll happen, but it might take a little time. But as it starts, I think as these pilots and we start to get the outcomes, I think that's going to give it the traction it needs.
Thank you.
Anne, would you like to? Thank you, Chair. Sorry. From a personal level, I've seen the difference to these services on Teesside with elsewhere in the country. I've got friends with children on the autistic spectrum. And years ago, the schools tended to try and ignore it. It didn't happen, just exclude the child when they kick off. It's not our problem. And I think we've progressed beyond that, but a lot of areas are still in that ball game. I despair because the children, and particularly autistic children during COVID, suffered an awful lot more. They lost their friends, they lost their routines. Now they're back in school. They are completely off the planet and at home. And the schools, in one case, the schools has taken away the statement of a child. You don't get better from it. And really said, well, you know, home tuition, because they need to prove to the educationists that school is getting good levels in exams and things, and these children are pulling down their stats. So I do think we might go wrong somewhere, but we are doing something right on that. You know, I despair for other areas.
A very quick response to that. What we're trying to do as well is actually focus on clinical needs of children. So, it, you know, and there's lots of bubbles of offer, particularly for ASD, for autism, ENTs that young people and their families can access.
Chair, on a practical note, seeing people are leaving,
Yes.
you can take some lunch with you. It's boxed up, so please go to where you had the... yeah.
Thank you very much for coming. Thank you.
Sorry.
Were there any other questions on that at all? Yes, certainly.
I was looking at that and thinking, when I read through, it was saying some of the waiting list times were over 2 years, and I was thinking, 2 years? That's such a significant part of a child's life. And you're saying that you're struggling with recruitment to get the people you really want in the right places. And I just wonder how we're going to pick it up properly. I can see where you're coming from and the mental health in schools assistance, but it's such a lot of backlog to actually pick up and actually to work through and get there.
It is, which is why we're trying to streamline things to try and sort that out. But I mean, it is difficult. The 2 years would relate to people on the autism assessment waiting list rather than other CAMS services. So it's waiting for that assessment. It doesn't necessarily mean that they're not having any treatment and intervention in that meantime, but it just means that it's a very small team of you know, it's a thing that we're looking at really closely to work out what's the best way of doing it, because the numbers are creeping up of the people that come in with those neurodevelopmental needs. So yeah, we are doing a lot of work on that.
I suppose, yeah, just to quickly add to that, we do in effect have two waiting lists. The one the data you've picked out there is very much waiting for that specialist assessment to get that diagnosis of autism. Whilst they're on that waiting list, there's a commissioned bubble of support with other providers who provide practical support to families whilst they're on that waiting list to provide that hands-on support. And I think that the people who need to come in to get the mental health and emotional wellbeing treatment into that iThrive system, the waits are generally improving as a result of the work we've touched on today. I think when we talked about benchmarking earlier, so when we benchmark those two separate waiting lists nationally, we do quite well on the mental health and emotional wellbeing waits, and we're probably comparable to the national picture for the autism assessment waits. And just to give you a flavour of a recent evaluation we did about capacity and demand, the referrals onto that pathway have gone up by over 300% pre and post pandemic. So it's just completely off the scale at the minute in terms of demand.
Thank you very much. I've got Anne, and then I've got Sarah after.
Thank you. After me praising you, I have a question. Because I used to work in this area many years ago. And at that point, people were so relieved when they got to the actual CAMS rather than the waiting list. It used to be horrendous. But at that time, if a child missed an appointment, their case was closed. Is that still the position? Thank God for that. That was awful. Thank you.
Sandra, did you want to ask a question?
Thank you, Chair. I'd just like to congratulate you on all the work that you're doing. I live and work in one of the most deprived wards, and I have never known a child wait 2 years. And that is a statement to your success. I do know that you work very hard with the voluntary sector, and the voluntary sector pick up a lot of the work on your behalf. But I honestly haven't known a child to wait 2 years in this area. Other areas, yes, but not here. No. Yeah, I know. I'm saying it. Yeah, I mean, like I say, that must be extra. an example of their good work. A child was, this is from another hat that I wear, school governor. A child was referred to CAMS with suspected autism. He's now been diagnosed, and it's only took 7 months. And I think that is something that needs to be, and it's like you say, it's recognising who needs what, where, when. But well done.
Well, yes, I've been you now.
Yeah, sorry, just to add, the Commission continues to monitor the actions that are being taken by the Trust through direct engagement with the organisation, but also through the quality boards that have been put in place across the system. And just to add, I think it's important to say today that as we're talking today, we've got an inspection team on one of the Trust sites, so we have got ongoing activity at the moment, and then obviously we'll report through in due course in relation to that.
Thank you very much for that. Was there, were there any more questions at all? Oh, thank you, Dave.
Yeah, thank you, Chair. Not a question, more a reflection, and conscious of the time, so I'm not going to ramble on for everyone today. Just thank you to colleagues in the Trust, really, for being so open, honest, and I think realistic and pragmatic. There's some national challenges that we've heard about that affect everybody, sadly, and there's some local stuff, and I'm really pleased to hear the progress, the immense amount of effort that's going into the local bits, the bits you can control. And just coming back, it was a conversation about CAMS that made me think about this, to be honest, that we're all around this table for the same reason. Yeah. We all want the Trust to be successful, not because it's the Trust, but actually for the patients that it serves, the people it serves. And I think that's why we're all here, why we all get out of bed in the morning. And it just brought it home to me, the CAMS bit. We talk about the trust in an organisation, and actually no organisation works as an island. I'm from an organisation that commissions from the Trust. You're representatives from organisations that have links in the CAMS bit, and the I Thrive model really brings it home. This is all of our business, so I think the fact that we're all here today, and hopefully it's been useful for Scrutiny colleagues, the fact that actually you understand the context, I think you've asked some really good questions which will help the Trust. For me, it's about how we work together so we support the organisation to get where it needs to be and wants to be, and recognise the patience that's required for that. I think, Brent, you started by saying actually it's a journey. There's a long way to go. There's lots of progress, but actually we need to help people along the journey and criticise and critique and be constructive. But actually, the way you've done the meeting today, I think for me has been spot on. For me, that's what Scrutiny is all about. So I've really enjoyed being here today, really enjoyed listening to the progress. Tons more to do, but I think, it bodes well for me, I think, to see that actually you're all supportive of the approach, and we need to help the Trust get on with things, not bombard them with lots and lots of challenges. We need to coordinate that, and obviously you mentioned the quality group, Brian, and other things that are going on, so you can actually get on with a job that you're obviously working really hard on to make the improvements that there. So, yeah, just thank you from me.
Thank you very much indeed. Thanks for that, Dave. And thank you. I just want to say thank you before we go on to the work programme. I want to thank everyone for their input, and thank you to my colleagues for all the questions. I had a pile of questions and everyone was so efficient in asking them. I've managed to tick them all off, so you've spared me the time. But I know one of my colleagues over at Darlington, she's just been the mayor, and she's just finished her term as mayor, Cindy Hughes, quoted, and it's probably a very famous quote, and I can't remember who it was, saying that scrutiny should be thought of as a critical friend. And I think that's something that a lot of us have talked about, that it's great to hear the good news stories, and we're not here to be sort of critical and to sort of tell people off, but we want to hear the difficult information as well. We need to hear that so that we can understand, how we can sort of help, or how we can sort of lobby for you, or sort of ask for help, for you, or sort of highlight issues that you need, but also to see how, when you're working through things, that we can say to our residents that this is the case, this is what's in place and what's happening, and then we can come back, because we need to know both sides, I think, good and bad, don't we? So, but thank you very, very much for that. I think management was actually praised for their the culture of openness at management levels. So, and I think, once you sort of connect the dots, it'll help. I had a sort of thing about integration, the idea of schools CAM's sort of presence in schools, and I think everything being integrated is the watchword at the moment, isn't it, with the ICS and ICVs coming in. So it'd be lovely at some point if we could get some further information about that, if anyone was interested in having you back for it. So I think that will bring us onto the work programme. So, so have you all got a copy of the work programme for the next, when's it for the next year? This is Hannah's work. Yes, so.
Do
Thank
take
you
a
very
box
much
of lunch
indeed.
with you.
Right.
Do take some lunch.
What do we have to do? Just, yes, please. Yeah.
Chair, can
Yes.
we not move the work programme onto the next meeting?
We could do, yes.
It's just I've got other meetings to
Yeah,
be, and I
that's
believe
absolutely
other people
fine.
have as well.
No, that's quite all right. I'd just like to say that I did ask Hannah if it was possible to bring, put dental services and some kind of work with dental services on, because it's something that we need to be looking at. I don't know how we're going to find answers to that, but I think it's something I want to add to it. So if we put that onto the next meeting, if that's all right with everyone, and then I think we could maybe add that on if that's possible. That'd be great. So is there anything else that we... I think that just remains for me to say thank you to everybody. Thank you very much indeed for everything and for...
And Chair, if I may just close
Certainly.
from our side and also thank you for your time, recognising you've had to put effort in to be here today. And I'm sorry we've run over, but we have a lot to talk to you about and a lot to show you. And, you know, we do welcome these dialogues. They do feel as if they're what the world should be about. Actually, this is, you know, critical friend stuff, and we're very happy to continue dialogue with you on all sorts of threads that we've started today. And in principle, if you want to come out to some other part of our service, you know, if the team don't faint when I say this, you can come and visit CAMS or come back here, because you really are very welcome. And now on the practical point, there is lunch next door where you had your coffee, and you can take it away in a lunchbox if you need to go swiftly. But can I just thank everybody from this side of the table as well who did an immense amount of work, and colleagues behind the scenes to set this up. Thank you.
Thank you. It's been amazing. Thank you.